important for you. And we'll go for sinus bradycardia and AV block. It will be difficult, but I hope it will be easy, inshallah. And we'll go for the phenomena of left bundle branch block and right bundle branch block. So the diseases started from the sinus node to this AV between the sinus node and the AV node in this fiber, then the AV node, then in the Purkinje fiber, and the Purkinje fiber it will be divided in right and left bundle. So we'll take it one by one, easy. Okay. So what is bradyarrhythmia?
Slower heart rate.
Okay, good enough. So it is a slow heart rate. Okay, less than 60, and can affect either the sinus node to start with, either the sinus node, or it can affect the AV node or bundle branch block. So in between the sinus node and the AV node, there is what? There is a fiber, which is, we call it atrioventricular fiber, and between the AV node and the bundle, there is a bundle of His, which is not included in your lecture. And this is simply to know the ECG manifestation. You need to know what is the pathology. So you can simply recognize it. ما تحفظوها, just try to understand. So as before, if there are diseases in the sinus node, what will happen to the ECG? There will be, for example, there is no sinus node. There will be no B wave. Simply, okay. This is one pathology, and if the disease is between the sinus node and AV node in this fiber, in the ECG, it will reflected by what correlate?
Which fiber?
Sorry? Yes. So this is the B wave. If there are diseases in the sinus node, it will be reflected in the ECG by abnormality in B wave. So, and if there is diseases in the fibers between the sinus node and the AV node, it will be reflected in the ECG by BR problem, prolongation of BR, because it is correlated with the ECG. And if there are diseases in the AV node, it will reflect in the ECG by what we call it block. هناخدها اليوم إن شاء الله. And if there are diseases in the bundle branch block, which is the left bundle, right bundle, it will be reflected in the ECG by simply left and right bundle branch block. So you can correlate the pathology with the ECG manifestation. This is important. هذا حيسهل. It will be easy for you when you go home and study. Okay. So the sinus node, it will be supplied by RCA, as we mentioned before. Any right coronary occlusion, you have to check the conduction system abnormality. Okay, and it can increase with the parasympathetic and parasympathetic activity. It will be increase and decrease accordingly. And AV node, it's supplied also by RCA. That's why the right coronary inferior MI is important. Why? Because we know the right coronary supply the AV node, supply the sinus node. Okay, and the Purkinje fiber, which is, we can call it this one. This is left and this is right. So it's supplied also by RCA and sometimes by LED. So it's important. So in general, bradycardia is slow heart rate, simply slow heart rate. Okay. And as we said before, any abnormality in the sinus node can be reflected by sinus bradycardia or abscess in the V wave. Simply, any problem in the AV node can be seen in the ECG by first degree block, the second degree block, and third degree block. And if there is a problem here, it will be reflected in the ECG by bundle branch block or other terminology. Clear, guys?
Yes.
Okay, so we can start now. Okay, but sometimes for the student level, we love to ask about causes and differential diagnosis. This is very important. So, what are the causes of sinus bradycardia?
Maybe ischemia.
Okay.
Ischemia to the SA node or occlusion of the right coronary artery.
Mumtaz. Other differential diagnosis? Medication, very important. This is medication very important, like digoxin, like beta blocker, calcium channel blocker can give you bradycardia. Like electrolyte imbalance can give you also bradycardia. One hidden, ما قلناها هنا في slide, what is it? Very, very, very important.
metabolic syndrome.
Metabolic cause, what is it?
Hypothyroidism.
Hypothyroidism. Be careful for hypothyroidism and hyperthyroidism. Clear? And sometimes will be pathological, mean cardiac problem, like congenital, patient was born with congenital heart disease, born for example with Down syndrome and has complicated congenital heart disease. Some of them they will have bradycardia. Degenerative, which is the most common with this is MCQ question. Clear? Ischemia, infarction, as Roa said, and for example maybe there is rare causes like infection, infiltrative disorder, inflammatory disorder, post-operative, and other like hypothyroidism. Okay, so you need to remember the causes. Okay, really for a student level you need to remember the causes. Okay, so now we'll come to the sinus node problem. Sinus node, it means abnormality in the sinus node impulse formation, and maybe sometimes the terminology for you is not important. Either you call it sick sinus syndrome, sinus arrest, sinus exotoblock, it is all the same for student level. And all these, there are few things to differentiate between them in the ECG. But for you guys, just remember one of them, either sick sinus syndrome, sinus node dysfunction, whatever term used. Okay, there is one terminology here. This now start to be like problem in clinical practice. They call it chronotropic incompetence. Mean Java. What does that mean? Nurhan, here. What does chronotropic incompetence mean? In English terminology يعني. بالأرمني والإنجليش تقريبا لما تسوي مع بعض إيش يطلع. Incompetence معناها is not good enough, صح?
Yes.
Not good enough. Chronotropic is not responding. So this terminology now we use it frequently. It means when the patient exercise, the heart rate is not going up. Simply, when you exercise, تروح الجيم ولا ما تروح؟ بالبيت. So the heart rate should increase, صح? If your resting heart rate, for example, 80, and you start exercise, the heart rate must be increased.
Yes.
But those patients, the heart rate is not increasing. So they have strange phenomena, unknown pathology. So they call it chronotropic incompetence. Clear?
So like the heart rate is fixed?
You cannot call it fixed, but it's not increasing with exercise. For example, it is 80, maybe it will increase to 82, 83 maximum. But when you're going to exercise, there is equation. It is 200 minus the age. لازم توصليها. And for example, if your age like 20 and 200 minus the age, you have to reach 200. Okay, so if you did not reach that, there is something wrong in the sinus node. Okay. So simply, just remember this, and the heart rate is not responding to exercise. So they have problem in the sinus node. So, but sometimes, as we said, sinus node can be physiological. Okay, how can differentiate physiological sinus node bradycardia from other bradycardia? Simply, the sinus node, there will be clear B wave. Okay, حيكون في clear wave لكن RR interval أكثر لو حسبناها تطلع less than 60. In this diagram we can calculate it now. So we'll go to the basic now. Who want to answer? اسمك انت ايوه حجازية. So now you're going to answer for the student where's the B wave. Okay, yes, only this question, very difficult question. So Hijazia said this is the B wave, doctor. Okay, you did not say, but go عليك. So this is the B wave. Okay, if not this one, well, this one. Yes, this is the B wave. So some students, they are not convinced. They said, explain to us, please, why this is B wave? Why not this one, the B wave? It's not only by looking, we have to have something scientific. Exactly, that means B wave comes before the QRS. Okay? And B wave is small, start sharp and end sharp, not like the T wave which starts slow and end slow. So this is the definition of the B wave. And after the B wave, there is a small, tiny, negative R wave صح. ما دائما تقول عن هذه R wave. Why is it that? From the previous lecture. Okay. So what is this wave, حجازية? This is a Q wave. Agree, guys?
Yes.
This is very important. We'll keep doing this again and again, please. And this is R wave. Okay. And this is small, tiny, also R wave, isn't it? No, this is S wave. So if Hijaziya said this is negative R wave, she is right or wrong? She is wrong. She will not say that, I'm sure. Okay. Then there is a T wave. So the space between this R and this R, if we calculate it, yes, RR, we can 1, 2, 3, 4, 5, 6, 7. So it will be 300 divided by 7. It will be for sure bradycardia. So this is an example of sinus bradycardia. So if you said bradycardia is not enough. You have to mention why this bradycardia, sinus or non-sinus. So in this patient he has sinus bradycardia. So what are the causes of sinus bradycardia as we mentioned before? Medication, hypothyroidism, hyperkalemia, ischemia. Very, very good. Okay. So sinus node exit block means the sinus node is firing impulses, but it got blocked. We don't know why. Maybe there is some pathology in the sinus node, but it got blocked. So the problem not in the formation of the impulses, but for delivering the impulses. And this block, it happens in the sinus node itself. Okay. And this is example. So there is a B wave here, which is very clear before the QRS and is small. And then there is a B wave, which is very nice. There is R wave. Maybe there is some ST segment changes here. If you notice that.
Depression?
Sorry?
Depression?
Yes. Then there is a line here. Okay, so there is something wrong. Where is the activity? Where is the ventricular and atrial activity? في ولا ما في? It's only a line. So this they call it sinus arrest, sinus exit block, sick sinus syndrome, whatever term used. This is good enough. Okay.
How do I differentiate it from a premature
Yes.
atrial contraction?
How we can differentiate between?
Because it looked between and premature atrial contraction because it looks very.
Yes, this is very, very good question. Because there is a phenomenon of the heart in the heart. If there is premature atrial contraction or premature ventricular contraction, there is a phenomenon in the heart. In the heart, there's a lot of phenomena. Nobody knows why, but they call it pause. After the premature atrial contraction, there will be a pause. Pause معناها nothing that will happen. كأن الهارت يبدأ يشغل نفسه من جديد. We don't know why, but they call it pause. Okay. In this patient, in this ECG, the pause we call it sick sinus syndrome, simply. Okay, but you are right. You can ABCs. It is rare causes of pause. We call it a pause in the ECG. Or yes.
Doctor, won't we have like a different shape of the B wave in case of premature atrial contraction?
This one?
Yeah, in
Yes,
case of
as you said, yes, maybe. But the concept here is there is time for no activity in the heart. No activity in the heart, okay? So they call it simply pause or sick sinus syndrome or sinus exit block. Okay? Then the sinus node starts again. Okay? Then there is a B wave, then we start the ECG again and again. Clear? So simply if you saw a line in the ECG, that's mean we call it sick sinus syndrome. Whatever syndrome mean a group of disorder. So maybe the sinus node exit block, maybe there is arrest of the sinus node, maybe there is, as we said, ABCs. Okay, but in the exam we'll bring something pathological. There will be a scenario. For example, patient came to ER with syncope. Those patients they came with syncope. Okay.
skip beat.
This could be in the clinical history. If you ask the patient how you feel your pulses, you said I feel one of the beats skip.
This is one of the characteristics, right?
Yes, this is في history. بنسأل المريض how this what's wrong with you? He said I have skip beat. Okay, because he feels it. Clear?
Doctor, so sinus arrest is the same as exit block?
For you, it will be the same. because there are some ECG manifestation for both of them. Very tiny differences. Don't worry about it. So in summary, there is a B wave, then there is a QRS, there is a B wave, then a QRS, then there is a B wave here. One of the colleagues suggests maybe this is ADC. This is very good thinking. Then there is a pause, or there is a line, okay, with no ventricular activity. And the left ventricle is waiting for the impulses. The left ventricle is calling the sinus node, why you did not send impulses today? Okay, I'm sick today, I will send impulses now. She is sending impulses. Sometimes the sinus node cannot send impulses. The sinus node is very sick. So the ventricle has its own rhythm. So the ventricle will activate what we call a junctional rhythm or ventricular rhythm, as we said in the previous lecture. So assume this ECG, there is no B wave here, no B wave anymore, no B wave here anymore. So this is not sinus rhythm again. This is what we call a junctional or ventricular rhythm. So the sinus node is not good enough to send impulses. So the ventricle has backup rhythm. Okay, clear? I hope you remember the previous lecture. Arwa.
Yeah.
قرأتيها ولا ما قرأتيها؟ Okay. So sinus arrests will be the same for that exit block. And the exact definition of sinus exit block, or to call it pathological, it has to be more than 3 seconds. Why is it 3 seconds? Because the likelihood of symptoms will be high. Okay. This you need to remember this definition. So more than 3 seconds. 3 seconds يعني نص ال ECG. كل ال ECG be done in 6 seconds. Okay. If there is more than 3 seconds, that means this patient has very advanced disorder and he needs a new sinus node. How we can give him new sinus node? Pacemaker. It's not ICD, remember, because some students they have confusion. ICD for shock, but pacemaker is for basing all the time. So like this example, there is sinus node, there is ST segment changes, then there is a pause. Okay, if the patient, we can't do ECG for any patient, we can find this abnormality. If he's asymptomatic, we'll tell him you have diabetes to control it, hypothyroidism to control it, beta blocker, we can reduce the dose, digoxin, we can hold it. But if he's symptomatic and more than 3 seconds, so he needs pacemaker. Okay, like this example. There is sinus node, sinus rhythm, then there is a pause here, very long pause. So if the patient has symptoms, syncope, we know this is from cardiac point of view. So we put a pacemaker for the patient. Clear that? So any problem with the sinus node diseases in general? So to recognize it, there will be only a line. The ECG, you are not required to know more than this. You need to know the differential diagnosis and how you're going to treat it. And you need to know the pathological definition, which is more than 3 seconds in the sinus rhythm. In atrial fibrillation, it will be more 5 seconds.
So sinus exit block is less than 3 seconds prolongation? Can you say that?
Sinus exit block has something with ECG manifestation. If you want, I can explain it, but it's very difficult. حتسوي لكم خربطة شوي. So just call it 6 sinus syndrome. It will be good enough.
Doctor,
Okay. So this is the phenomena of chronotropic incompetence. As we said, the heart rate is not going up with exercise. So the patient may have symptoms. When he exercises, he will have symptoms of syncope, dizziness. So those patients, they are born with sinus node dysfunction. And this is simply diagram. Now we finish from the atria. We'll come to the ventricle. Okay. This is the AV node. Below the AV node there is something called bundle of His. And there is left and right bundle. This is the anatomy of conduction system in the ventricle. Before to start with this, any question in the sinus node? So you need to know sinus bradycardia very well, very well. You need to know pause or 6 sinus syndrome very well. you need to know the differential diagnosis, and you need to know how to recognize it in the ECG, which is simply a line. Clear?
What is the difference between the sinus syndrome and the sinus arrest on the
There is, as I said, there is tiny differences between the sinus syndrome and sinus node exit block in the ECG. You are not required to know that now. Okay? Any question? Other question? Nothing? Okay. So now I'll come to the most important thing, which is diseases in the ventricular conduction system. And why it is important, Nurhan? Because it's serious. Any problem in this conduction system can give you low cardiac output for your patient, and maybe you will have symptoms. Symptoms of arrhythmia, symptoms of syncope, symptoms of arrest or something like that. Okay. So the arrhythmia can be at the level of the AV node or at the level of bundle, either right or left. Simply, diseases here, diseases in the left bundle, diseases in the right bundle. Clear? So we'll go through this. So as we said, first degree AV block. Okay, this is first phenomenon happen in AV block. That means there is a block, but from the name it looks like first. معناتها it's okay, and it's not serious, صح? So the disease is here. It will be not serious, first thing, and the problem it will be from the AV node and above. So it will be in the fiber between the sinus node till AV node. So it will be reflected on the ECG by BR prolongation. And you remember from the first lecture, BR duration not more than 5 small squares. If more than 5 small squares, that means BR is prolonged. So in this ECG, there is a B wave, but you notice the space between the B wave and the QRS is really more than 5 small squares. Agree? The space between the B wave and the QRS is very, very far away. Okay? The space between this and this is far away, far away, far away. But in general, the B wave is reaching the ventricle. So there is no real block here. So they call it first degree AV block. So what is the pathology here? If you go back to the previous one, the problem between the atria and the ventricle, especially above the AV node. It will be, so those fiber got disease. For example, patient has diabetes, has hypertension, filtrative disorder, rheumatic heart disease. So those fiber got disease. So the electricity to pass through this fiber, it will be very difficult. Okay? It will be reflected on the ECG by BR prolongation. Clear? Anyone can explain? Yes. Yes, please.
So the first degree block basically happens due to pathology fibers between the SA node and the AV node. And because of that, we would see a prolongation between the two
Yes.
arms.
So, but at the end, be careful to the end, because we are really interested at the end. What will happen? At the end, this impulse, it will reach the ventricle, and there will be clear QRS. Okay? So this they call it first degree AV block. It is benign disorder. It will not cause symptoms most of the time. If it is very, very, very prolonged, يعني تقريبا 2 big squares or something like that. In physical exam they call it. What is the sign in the physical exam for prolonged, very prolonged BR interval? أخذتوها؟ So just think about it. Now the sinus node fire impulses, one impulse, and this impulses reaching the right atrium, and the right atrium now contract. But this impulses did not reach the ventricle yet. So what will happen to the tricuspid valve? It will be still closed. صح? So the atria will contract against closed tricuspid valve. البلاد فين حيطلع؟ في الجاكولار. So they call it
high GBP.
GB. So they call it canon A wave. This is the canon A wave. نسيتوا physical examination؟ ولا لسه ما أخذتوه؟ ما أخذتوه؟
Doctor, does it will affect the GBP?
Yes, it will be very high GVB. They call it canon A wave. I thought you took the physical examination. So just forget that. So clear now? So if I ask you, any one of you, the B wave in ventricular activation in first degree AF block, it will be okay or abnormal? No, ventricular activation. I mean ventricular activation in the ECG معناتها ال R wave أو ال QRS in general. تكون موجودة ولا abnormal? Are you sure? Yes. It will be there all the time. Okay? So there is no absence, we can call it, of QRS موجودة all the time in first degree AF block. It is benign disorder or serious disorder? Benign disorder. Sometimes cause symptoms if it is very severe. Okay, so now we'll go further. So the disease is now is getting worse. Okay, the patient has uncontrolled diabetes, hypertension, he has respiratory disorder, whatever diseases he has. The disease is progressing. And the sinus node, the disease reaches the sinus node. So what will happen to the ECG? Okay, there is a B wave, then there is a B wave, then there is no QRS here.
Skip.
There is no QRS here. What happened? So the problem here, where? It is in sinus node or in the AF node? In the AF node. And the God create the AF node. It has very special characteristic. The AF node will get disease, it will close. Okay, it will not open for any arrhythmia to go to the left ventricle. It's like a protection for the left ventricle. So if the disease, the AF node get progressed, the AF node will get block everything. Nobody will go in now today. I am sick. Okay, it's like a door and being closed. Okay, so in this ECG, we'll go through this ECG together. So there is B wave and there is a QRS. So, is this a B wave? Are you sure, guys?
Yes.
Okay. This is R wave.
No.
Why?
Q.
Okay. It's up to you. So this is the BR interval. But remember, in this pathology, the AF node is very diseased. So the AF node is struggling dealing with those impulses. The AF node is sick. So impulse number one, we can call it impulse number one. Okay, the AF node check this impulses and send it to the left ventricle. Okay, no problem. In the second, but the AF node also is sick. Okay, for example, the AF node took time here. For example, 5 seconds. For example, to analyze this impulses. But the AF node, remember, is sick. So when the AF node finishing from analyzing the sinus node here, she will get immediately another impulse. So she will take more time analyzing this these impulses. So it will take more time. More time, it will reflected on the ECG by prolonged BR. For example, if the BR here is 200 millisecond, the AF node, remember, is sick. So it will take more time. It will take like 250 millisecond now. Okay? In the third impulse, the AF node will take 400 millisecond. Okay? But when it comes to the other, to the fourth or fifth or sixth B wave, AF node said, please, I am sick. I cannot handle it. I will block everything now. I will take a rest. Okay? So the AF node will close completely. Okay? So there will be a B wave, but there is no QRS. Okay? So this is the definition of Mobitz type 1, with what we call it Wenckebach phenomena, whatever term used. And I remember one of the students, she will ask, but doctor, what is the difference between AF block and a pause. Why not this a pause? Yes, there is a pause. Clear? Sorry? So why this not a pause? Exactly. So there is a B wave here. So we cannot call it a pause. There is a problem in the AF node. A pause, a problem in the sinus node. So you got the point. Definition of Mobitz type 1, it is progressive prolongation of BR until B wave got blocked. Why? Because the AF node is very diseased. Okay. Yes.
How can you differentiate from the second degree AV block from the sinus block? Like you have very similar the sinus block and the second degree AV block.
So you mean sinus block? It is difficult now. It is difficult to differentiate. That's why we need to neglect sinus exit block for now. Okay. So we cannot give you both. But actually, if you go deep, you can. هنتكلم عنها. So now you got Mobitz type 1. Any one of you can repeat or explain. Yes, please.
So if Mobitz type 1 is a physical limitation of the BR inhibitor until the period,
Then the B wave will not be conducted to the ventricle. Why? Because the AF node is diseased. So the AF node decide to take a rest to close. I will not work today. I get sick leave. Okay?
Does it disappear?
Sorry?
At some point, does it disappear?
Yes. Because now there is like a sinus in the heart. What's happening in the heart? So the left ventricle is concerned. What is my B wave? What is my impulses? So the B wave, the left ventricle will send a message to the sinus node. Why? What's wrong with you? The sinus will say, I have nothing wrong with me. The problem in the AF node. And the AF node will start working again. If not, remember the heart has a backup. So the left ventricle will start working either by junctional or ventricular rhythm, but there will be no B wave here. Clear? Clear Mobitz type 1? Is this pathological all the time? No. Mobitz type 1 can be physiological during sleep. For people who are athletes, they can have Mobitz type 2, type 1. That means is not serious and rarely cause symptoms.
But he said that the AV node is diseased.
Yes. Sorry?
Isn't the AV node
Yes.
diseased?
Yes.
So how is it not?
How is?
How is it not a pathology? Like it's nothing to do.
Yes, but it is not pathological clinically. Will not give symptoms. If the patient has syncope and he came and you did ECG, you found Mobitz type 1, yes, it is a cause, but look for other causes. Okay? So it's not all the time pathological. Okay? I mean clinically. Clear? So Mobitz type 1, type 2 now, which is really pathological. All the time pathological, all the time causing symptoms. Okay? So here, there is B wave, and there is a QRS. B wave, there is a QRS, and this is another B wave.
QRS are abnormal.
This is another B wave. Cannot be?
This is T wave.
This is T wave? Okay, agree. Then there is a B wave, then there is a B wave, then there is a B wave. If you try to focus here, BR interval is getting prolonged or not? Not really. If you brought something in the exam, brought it very clear for you. The progression will be very clear. But in this patient, the BR is not, it's fixed. In this, maybe here, 5 small squares maybe. Here it's almost the same. Here is almost the same. Here is almost the same. Here is almost the same. But now we have B wave which got blocked. Okay? So what's wrong with this B wave? So this B wave blocked by AV node. Why? Because the AV node is very diseased. Okay? Advanced disorder in the ECG, in the AV node. So there will be no progression. The AV node immediately decide to take a rest. There is no progression. يعني بالعربي كأن ال AV node في الفيرست degree بتاخذ على نفسها تتحمل، لكن here no. I am sick, I am sick. Okay? That's why the patient all the time they have syncope in this point. If there is no QRS, they will have syncope. They will have dizziness. So this is must cause symptoms. And those patients they need pacemaker immediately. خلاص. Okay. Yes, sure.
Doctor,
Yes.
can you say that the QRS is abnormally shaped?
Yes. This is another phenomena inside the QRS. If the advanced disorder affecting the AV node, معناته is on the way for Purkinje fiber, and they have wide QRS أحيانا. Okay. But if they have narrow, I got your question wrong. If they got narrow QRS, that means the disorder is not advanced yet. يعني لسه ما وصل للبركنج fiber. If the QRS is wide, احنا نقول عنه he immediately go for pacemaker. But if it is not, نحط pacemaker بكره بعد بكره no problem. Okay?
He's still in the mild stage.
Yeah, it would be good enough. So the QRS widening, remember, is all the time serious problem. دائما. دائما دائما. Okay? So here, what's your name? Rawan. Rawan is saying this is the T wave. Okay? Then there is B wave. Okay? If we are following this ECG, we will find B wave, then there is a QRS, B wave, then there is a QRS. They are look good, mashallah, nothing wrong with them. B wave, then there is a QRS. But here, there is no QRS. What's wrong with this ECG? We'll go back. This is a T wave, then there is a B wave. So by default, this B wave, which is recorded here, must be blocked. Why blocked? Because there is no ventricular activation. A block معناها there is no ventricular activation of this B wave. Okay. So if there is a QRS here, it will be خلاص, there is no block. But now this B wave blocked. That means either this impulse is not healthy, is pathological, or there is a problem in the AV node. No other reason. Okay. So in this patient, the B wave is normal, nothing wrong with the B wave, but there is a block. That means the AV node is very, very sick. Now our job to differentiate Morbus type 1 from Morbus type 2. So we'll go back. Is there any prolongation of BR? Not really, nothing. If there is, it will be clear for you. Very, very clear. But there is a blocked B wave. That means Morbus type 2. Morbus type 2 is all the time pathological, all the time need attention and treatment. So that the definition of the Morbus type 2 is fixed BR plus blocked QRS. Simply, okay. Type 1 it will be less clinically presentation. حيكون مثلا مريض عنده dizziness شوية تعبان. لكن type 2 most of the time they have syncope. Okay, they came to ER with syncope. Okay, and after the syncope in this time, remember that what will happen to the next. So the sinus node will start again, and there is a cycle. So في differential diagnosis they call it group beating. كأنها جروبات مع بعض. حيكون في جروب هنا. بعدين في بلوك، بعدين في جروب، بعدين في بلوك، بعدين في جروب. So they call it group beating. لما تشوف الإيسيجي من بعيد كأنه جروبات. Okay. Clear? Morbus type 1, Morbus type 2. This is very important for you guys to, especially Morbus type 2. Why? Because it is all the time pathological. Okay. So here is fixed. Those line means fixed BR, fixed BR, fixed BR until blocked QRS. If you go here, it will be prolonged, prolonged, prolonged until the B wave got blocked. زي ايش بالعربي لغة البي ويف التي ويف الاف نوت كان ايش تاخذ على نفسها لكن here I am sick I will not work anymore. Then if the disease progress in the sinus in the AV node, we started with Morbus type 1, then Morbus type 2. Now there is very advanced disease for the AV node. So the AV node will close. No more. No more of AV node. The AV node will close completely. So there is a phenomenon inside the heart. We call it complete heart block. Not first degree, not second degree, we call it complete. Okay, or third degree AF block. وش معناها؟ Can you guess? Exactly. So there is the definition is complete disassociation between the atria and the ventricle. The atria is contracting for their own, and the ventricle contracting from their own. So both ventricle. كأنهم صاروا two organ now, two different organ. Atria is contracting لوحدها, والventricle is contracting alone. So they call it complete disassociation. Why? Because the AF node is very sick. So the AF node will not, if it is sick, it will not allow all the impulses. No, it will block. Because the AF node knows the atria has its own rhythm and the ventricle has its own rhythm. ما في مشكلة. Okay? But those patients, they came with syncope all the time, and it is serious rhythm. You have to treat the patient by putting them pacemaker. So in the ECG, it will be the atria, it will be recorded alone, mean B wave alone, and the QRS, it will be alone. As this in the ECG, the B wave sometimes it will be here, 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 sometimes it will be here. So the complete disassociation. And before the QRS, there will be no consistent B wave. There is no clear B wave here. So this patient has junctional rhythm plus sinus node is recording لوحدها and ventricle is recording alone. Because it requires complete disassociation between the atria and the ventricle. In the ECG, P wave it will be recorded alone and the QRS will be recorded alone, and there is a backup rhythm for the heart, they call it junctional rhythm. Okay, so this is now junctional, it is not sinus anymore. Why? Because there is no B wave before the QRS. Okay, this is what they call complete AF block. So all the time this patient needs pacemaker. So bundle branch block. Now we have diseases affecting the sinus node. We have diseases affecting the fibers between the sinus node and the AF node. We have diseases affecting the AF node itself, which is Mobius type 1, Mobius type 2, and complete heart block. If the disease is progressing now, reaching the bundle of His, which is right and left. So there is a phenomenon inside the heart, they call it left bundle branch block from the terminology. Either left gut blocked or right gut blocked. Each one of them has its own ECG manifestation. But simply, it will be very simple for you. ما في هنا diagram, إلا في diagram. So this patient, for example, he has sinus node is okay, no problem. He has AF node, no problem in the AF node. But his problem in the left bundle got blocked. Here, left bundle got blocked. For any reason, either ischemia, trauma, infarction, whatever. Okay? So what will happen to the heart? Okay? What will happen to the heart? It will stop, or there is some backup rhythm, or there is something. Okay. So we can make a story from this. Okay. So in the left bundle branch block, what will happen? The sinus node it will reach the AF node. It will be delivered to the Purkinje fiber, but it will not reach the left ventricle. We start from the left ventricle, what we call left bundle branch block. So the left ventricle is asking, where is my impulses? Okay, so the sinus node will respond. Say, I already sent impulses, but did not reach you. It's your own problem. Deal with it. So the left bundle will say, okay, from where I can get electricity? I need electricity to contract, or the patient will die now. So what will happen? But the bundle completely blocked. There is no way. So there is no electricity at all. To start automaticity, there will be fibers, but here there is no fibers. So the left ventricle now is asking for help. Okay, تقطعت والصبر. Okay, so he's asking for help. So بيسأل asking for help from whom? جاره مين؟ The right ventricle. So the left ventricle texting the right ventricle said, please, I have no electricity. can you send me please some of them? Right ventricle said, Abshir, ولا يهمك, I will send the electricity for you. So the activation in left bundle will come from the right ventricle all the time. So this phenomena, it will be recorded in the ECG really like this. كيف بيصير؟ معهم. So we said the activity or the activation of the left ventricle coming from the right ventricle. Okay? فزع ولا okay? So when the electricity goes from the right, احنا قلنا نتذكر أول محاضرة, any electricity going toward the lead will be positive, صح? Any electricity going away, it will be negative. So those electricity going away from the right ventricle, it will be recorded negative in which leads?
Lead 1, lead 2.
Exactly. So it will be left bundle. First presentation, ECG presentation of the left bundle is deep S-wave. That means electricity is going away from the right ventricle. So it will be recorded deeply negative. لازم تكون deeply negative because all the electricity is going to the left ventricle. So this is first presentation. And when this electricity reaching the left ventricle, بتكون جاية من السفر تعبانة وحالتها حالة very tired. So it will be recorded weekly in V5, V6. So there will be small R in V5, V6, and it must be wide. Why? Because the left ventricle is very sick now. So two presentation of left bundle branch block on the ECG. One is deeply S-wave in V1, V2, small R in V5, V6 because it receives the electricity and it must be wide. هذا هو الديفينيشن حق left bundle branch block. Easy? Can you repeat?
Doctor?
So you can remember it at home by this small story. Okay?
Doctor, what about the leads 1, 2, and 3?
Okay. ايش فيها؟
Will we have like negative?
والله ما سمعت.
Will we have like negative complex amount?
Yes, this is other criteria of diagnosis of left bundle branch block. There will be changes in all the ECG because the ECG, all the electricity now change. So there will be changes also in limb bleed, but we don't care about it, okay? So as we said, lateral lead تقريبا بتكون بالضبط زي V5 V6. حتكون positive وتكون very wide. Can you repeat please? Because the right bundle نفسها بالضبط بس بالعكس. Can you repeat? Anyone of you, please? Please. Okay, why? Exactly. It will be small and positive, must be positive. لو negative معناتها انه this is not left bundle, there is something wrong. Why left bundle is important? Okay. Because it has pathological problem, okay, and prognosis problem and mortality problem. If the patient presented with chest pain and he has left bundle, that means he has MI, خلاص. He has what we call it ST segment equivalent, okay. If the patient is going to OR and he has left bundle, دائما لما المريض يروح for OR, the anesthesia people they will send the patient for ECG. So if we saw this patient he has left bundle, we'll tell the surgeon be careful. This patient has left bundle, he prone to complication. Okay, so left bundle all the time has bad mortality and morbidity. That's why it's very important. Clear? Anyone want to repeat or you are good enough? يلا واحد مرة. الناس اللي ما يشاركوا نهائي. You want to participate? Yes.
I didn't really understand.
No problem. She will explain to you. يلا.
So there will be a deep.
No, it's okay. You will listen for her. يلا فاهمة؟ أيوه.
So there will be a sub in the left bundle branch. So it will get the help from right.
Okay.
So because of that, it is going away from the lead, and that will cause a negative R wave.
Negative R wave with not negative. Deep is. ما قلنا there is no R wave negative here. Okay.
Okay, so in V1 and V2,
Okay.
and it will be small in V6 and 5.
Exactly. And it will be
and why?
wide. Must be a wide. لو مش wide, this is not left bundle. Okay? Clear? Left bundle is very important because it has prognostic problem. Clear? Anyone? She did not understand? Who said the doctor? Yes? You want to ask?
Like, what's the problem with V5 and V6?
The V5 and V6, the R wave, it will be positive, but it is weak. احنا قلنا ال V wave المفروض تكون big here, and it is wide. وتقريبا لها الشكل هذا اللي هو rabbit ear. Just ignore it. So it will be only a wide curve. Yes, this is as a diagnosis we are required for V1, V2. But if the S wave deep in adults, this is mainly advanced disease. This is good question. Very good question. Clear? Left bundle, remember it is very important. You got the concept?
Doctor?
Well, I cannot hear you. صراحة. We are very far away. Is S wave inverted? I cannot get the question, but I assume you are asking about S wave. S wave are required for diagnosis. That's why we are interested in the S wave now. Okay? I didn't know the question, but is this the question or what? It will be small. It's not like this. It will be small S wave, small, tiny, like this one, but not like this. It's very deep. Plus wide QRS. The QRS is wide. That means he has this combination. It has to be left bundle, nothing else. Okay. If you saw normal ECG, I don't know if we have normal ECG here, but I don't. It will be S wave. It will be not. There will be S wave, but it will not be deep, inverted, deep S wave. There is what?
Why is the S wave very deep?
Because it reflects the electricity. Electricity travel from the right ventricle to the left ventricle. And those electricity going away from V1, V2. Because V1, V2 is here. So the electricity is going away from them. So it will be recorded negative. This is the rule.
Doctor?
And right bundle will be completely the opposite. Okay?
Can we say that there is an I as well?
Yes, if the patient came with chest pain and has this ECG, this patient has an eye immediately. But remember, one of the problem with left bundle, if there's chronic left bundle from previously, you cannot tell this is the segment elevation, even the patient has chest pain. This is very details, you don't need to know it now. And this is right bundle. Now the problem in the right bundle here. So this bundle got blocked, so the electricity coming from the left ventricle to the right ventricle. Okay, from the left ventricle to the right ventricle. So the electricity it will be positive in V1, V2. Must be positive. Okay? And wide. So this is the definition of right bundle branch block, simply because there is positive R in V1. Remember, R on V1 should be small, tiny, but now it's very, very big. And wide, this is combination, we call it right bundle branch block. You?
Doctor, what about the depression of the T wave? There is depression.
T wave here?
V4 and V5.
This one?
V4,
V4?
yes.
T wave inversion, you mean? Yeah, T wave is deep because this patient he came with a problem, I'm sure. So maybe he has ischemia or other problem. Okay.
So the only thing is basically positive V1.
Positive V1, it will be positive and it will be big and it will be wide. Okay. Why is it?
Why is it like an action? Why is S2 not alone?
Yeah, this phenomenon they call it RSR. It means wide QRS only. You don't need to worry about this. So wide QRS means RSR, whatever term you use. We use sometimes fancy word, but this it will be